Okay, good afternoon. This is February the 24th. My day has not gone the way that I planned on it going, so my schedule's kind of off. But anyway, so today's readings was over wrist conditions in the Maggie book, and this is the Maggie book here. And these are the icons from the file. So, where are we? Let's start with the readings and get that on video. So, I'm making this mainly so when I'm in the gym and I'm doing cardio, I can pull this up on YouTube and watch it while I do my cardio. So I am going to enlarge this down to, let's say, 150. That way it'll be easier for me to see in the gym.
Upper limb urodynamic tension tests. Brachial plexus tension or LV test. The upper limb urodynamic tests, ULTT, are equivalent to the straight leg raising, SLR, test in the lumbar spine. They are tension tests designed to put stress on the neurological structures of the upper limb by stretching them, although, in truth, stress is put on all the tissues of the upper limb. The neurological tissue is differentiated by what is defined as sensitizing tests. For example, neck flexion with the SLR test. This test, first described by LV, has since been divided into 4 tests. Table 3, 18 inches. Modification of the position of the shoulder, elbow, forearm, wrist, and fingers places greater stress on specific nerves. Nerve bias. Each test begins by testing the good side first and positioning the shoulder, followed by the forearm, wrist, fingers, and last, because of its large ROM, the elbow. Davis et al. Felt the test should be considered positive only if neurological symptoms were manifested before 60 to the power of degrees of elbow extension when elbow extension was the last movement performed. Each phase is added until symptoms are produced. To further sensitivity to the power of the test, side flexion of the cervical spine may be performed. Symptoms are more easily aggravated into the upper limb than the lower limb when doing tension tests, and if the neurological signs are worsening or in the acute phase, or if a cataequina or spinal cord lesion is present. These stress tests are contraindicated. When positioning the shoulder, it is essential that a constant depression force be applied to the shoulder girdle so that, even with abduction, the shoulder girdle remains depressed. If the shoulder is not held depressed, the test is less likely to work. While the shoulder girdle is depressed, the glenohumeral joint is taken to the appropriate abduction position, 110 to the power of degrees or 1 to the power of degrees, depending on the test, and the forearm, wrist, and fingers are taken to their appropriate end of range position. For example, in ULTT the wrist is in full extension, figure 3, 42 inches. Elbow extension stresses the radial and medial nerves, whereas flexion stresses the ulnar nerve. Wrist and finger extension stresses the median and ulnar nerve while releasing stress on the radial nerve. If required, ULTT 2, 3, and 4, the glenohumeral joint is appropriately rotated and held. The elbow position is often not performed until last because the large elbow ROM is easiest to measure when recording available range to show improvement over time. As the elbow is taken toward its extreme, end of range, position, symptoms are 1 of 7. Usually felt. Some of these symptoms are normal, table 3, 19 inches, and some are pathological. If symptoms are minimal or no symptoms appear, the head and cervical spine are taken into contralateral side flexion. This final movement is sometimes referred to as a sensitizing test. This sensitizing test may be within or near the test limb. For example, neck side flexion in ULTT, or it may be in another quadrant. For example, right ULTT and right SLR. The tests are designed to stress tissues. Although they stress the neurological tissues, they also stress some contractile and inner tissues. Differentiation among the types of tissues depends on the signs and symptoms presented. Table 3, 20 inches, 2 of 7. Common hand and finger deformities. Ape hand deformity. Wasting of the thenar eminence of the hand occurs as a result of a median nerve palsy, and the thumb falls back in line with the fingers as a result of the pull of the extensor muscles. The patient is also unable to oppose or flex the thumb. Figure 713. Bishop's hand or benediction hand deformity. Wasting of the hypothenar muscles of the hand, the interossei muscles, and the two medial lumbrical muscles occurs because of ulnar nerve palsy. Figure 714. Flexion of the fourth and fifth fingers is the most obvious resulting change.
Boutonnière deformity.
Extension of the metacarpophalangeal and distal interphalangeal joints and flexion of the proximal interphalangeal joint, primary deformity, are seen with this deformity. The deformity is the result of a rupture of the central tendinous slip of the extensor hood and is most common after trauma or in rheumatoid arthritis. Figure 715. Claw fingers. This deformity results from the loss of intrinsic muscle action and the overaction of the extrinsic, long, extensor muscles on the proximal phalanx of the fingers. The metacarpophalangeal joints are hyperextended, and the proximal and distal interphalangeal joints are flexed. Figure 716. If intrinsic function is lost, the hand is called an intrinsic minus hand. The normal cupping of the hand is lost, both the longitudinal and the transverse arches of the hand, see figure 7.4, disappear, and there is intrinsic muscle wasting. The deformity is most often caused by a combined median and ulnar nerve palsy. Drop wrist deformity. The extensor muscles of the wrist are paralyzed as a result of a radial nerve palsy, and the wrist and fingers cannot be actively extended by the patient. Figure 717, 3 of 7. Dupuytren contracture. This progressive disease of genetic origin results in contracture of the palmar fascia. There is a fixed flexion deformity of the metacarpophalangeal and proximal interphalangeal joints. Figure 718. Dupuytren contracture is usually seen in the ring or little finger, and the skin is often adherent to the fascia. It affects men more often than women and is usually seen in the 50 to 70-year-old age group. Extensor plus deformity. This deformity is caused by adhesions or shortening of the extensor communis tendon proximal to the metacarpophalangeal joint. It results in the inability of the patient to simultaneously flex the metacarpophalangeal and proximal interphalangeal joints, although they may be flexed individually. Mallet finger. A mallet finger deformity is the result of a rupture or avulsion of the extensor tendon where it inserts into the distal phalanx of the finger. The distal phalanx rests in a flexed position. Figure 719. Myelopathy hand. This deformity is a dysfunction of the hand caused by cervical spinal cord pathology in conjunction with cervical spondylosis. The patient shows an inability to extend and adduct the ring and little finger and sometimes the middle finger, especially rapidly, despite good function of the wrist, thumb, and index finger. In addition, the patient shows an exaggerated triceps reflex and positive pathological reflexes, for example, Hoffman reflex. Polydactyly and triphalangism. Polydactyly is a congenital anomaly characterized by the presence of more than the normal number of fingers or, in the case of the foot, toes. Triphalangism implies there are 3 phalanges instead of the normal 2 as would be seen in the thumb. 4 of 7. Swan neck deformity. This deformity usually involves only the fingers. There is flexion of the metacarpophalangeal and distal interphalangeal joints, but the real deformity is extension of the proximal interphalangeal joint. The condition is a result of contracture of the intrinsic muscles or tearing of the volar plate and is often seen in patients with rheumatoid arthritis or following trauma. Figure 7, 20 inches. Trigger finger. Also known as digital tenovaginitis stenosens, this deformity is the result of a thickening of the flexor tendon sheath, not as nodule, which causes sticking of the tendon when the patient attempts to flex the finger. A low-grade inflammation of the proximal fold of the flexor tendon leads to swelling and constriction, stenosis, in the digital flexor tendon. When the patient attempts to flex the finger, the tendon sticks, and the finger lets go, often with a snap. As the condition worsens, eventually the finger will flex but not let go, and it will have to be passively extended until finally a fixed flexion deformity occurs. The condition is more likely to occur in middle-aged women, whereas trigger thumb to the power of with a flexion deformity of the interphalangeal joint is more common in young children. The condition usually occurs in the third or fourth finger. In adults, it is most often associated with rheumatoid arthritis and tends to be worse in the morning.
Ulnar drift.
This deformity, which is commonly seen in patients with rheumatoid arthritis but can occur with other conditions, results in ulnar deviation of the digits because of weakening of the capsular ligamentous structures of the metacarpophalangeal joints and the accompanying to the power of effect of the extensor communis tendons. See Figure 710. Zigzag deformity of the thumb. The thumb is flexed at the carpometacarpal joint and hyperextended at the metacarpophalangeal joint. Figure 721. The deformity is associated with rheumatoid arthritis. A Z to the power of deformity is due to hypermobility and may be familial. Figure 722, 5 of 7. Other physical findings. The hand is the terminal part of the upper limb. Many pathological conditions manifest themselves in this structure and may lead the examiner to suspect pathological conditions elsewhere in the body. It is important for the examiner to take the time to view the hands when assessing any joint, especially if an abnormal pattern is presented or the history gives an indication that more than one joint may be involved. For example, if a patient presents with insidious neck pain and demonstrates nail changes that indicate psoriasis, the examiner should consider the possibility of psoriatic arthritis affecting the cervical spine as well as the hand. Some conditions involving the hand include the following. 1. Generalized or continued body exposure to radiation produces brittle nails, longitudinal nail ridges, skin keratosis, thickening, and ulceration. 2. The Plummer-Vinson syndrome produces spoon-shaped nails. See Figure 711. This condition is a dysphagia with atrophy in the mouth, pharynx, and upper esophagus. 3. Psoriasis may cause scaling, deformity, and fragmentation and detachment of the nails. Psoriasis may lead to psoriatic arthritis affecting spinal and peripheral joints. 4. Hyperthyroidism produces nail atrophy and ridging with warm, moist hands. 5. Vasospastic conditions produce a thin nail fold and pterygium, abnormal extension of the cuticle. 6. Trauma to the nail bed, toxic radiation, acute illness, prolonged fever, avitaminosis, and chronic alcoholism produce transverse lines, or bowlines, in the nails. Figure 723, 7. Many arterial diseases produce a lack of linear growth with thick, dark nails. 8. Louise, syphilis, produces a hypertrophic overgrowth of the nail plate. The nails break and crumple easily. 9. Chronic respiratory disorders produce clubbing of the nails. See Figure 712, 6 of 7. 10. Subacute bacterial endocarditis may produce osseolar nodes, which are small, tender nodes in the finger pads. 11. Congenital heart disease may produce cyanosis and nail clubbing. 12. Neurocirculatory aesthesia, loss of strength and energy, produces cold, damp hands. 13. Parkinson disease produces a typical hand tremor known as pill rolling hand to the power of Figure 724, 14. Causalgic states produce a painful, swollen, hot hand. 15. Opera glove to the power of anesthesia is seen in hysteria, leprosy, and diabetes. It is a condition in which there is numbness from the elbow to the fingers. Figure 725, 16. Raynaud disease produces a cold, mottled, painful hand. It is an idiopathic vascular disorder characterized by intermittent attacks of pallor and cyanosis of the extremities brought on by cold or emotion. 17. Rheumatoid arthritis produces a warm, wet hand as well as joint swelling, dislocations or subluxations, and ulnar deviation or drift of the wrist. See Figure 7.10, 18. The deformed hand of Volkmann ischemic contracture is one that is very typical for a compartment syndrome after a fracture or dislocation of the elbow. Figure 7.26. Box 7.1 gives further examples of physical findings of the hand. 7 of 7.
Okay, so that's the readings. And okay, so table 318, upper limb neurodynamic tension test showing order of joint positioning and nerve bias. So in this book, they're actually numbering the test instead of calling it median nerve, radial nerve, ulnar nerve. So ULTT1 test the median nerve, anterior interosseous nerve, C5, 6, and 7. ULTT2 is testing the median nerve as well, the musculocutaneous nerve, and the axillary nerve. And then ULTT3, the radial nerve, ULTT4, ulnar nerve, T8, and T1 nerve roots. Which that's not how we learned it in school, so that's kind of new. So what's the same in all of these? Depression and abduction. Shoulder is depressed and abducted. Depressed and abducted. Depressed and abducted. And when we looked at the, listen to the reading, I should not have closed that out. It's stated in the reading that it's very important that the shoulder maintain depression, or else the test is not going to work very well. So in 1, 2, and 3, the elbow is extended. And for the median nerve, the forearm is supinated. For the radial nerve, the forearm is pronated. The wrist is extended. For the radial nerve, the wrist is flexed. The fingers and thumb are both extended. Fingers and thumb are flexed. And then for the 2 and the 3, you have lateral rotation and then medial rotation for the radial nerve. So internal rotation. External rotation for the median nerve. Internal rotation for the radial nerve. The cervical spine is contralateral flat side flexion. So on all of these nerve tension tests, the cervical spine is contralaterally side flexed on all of them. Okay, so 2 medium nerves. 1 does the anterior interosseous nerve, and 2 does the musculocutaneous nerve and the axillary nerve. 3 is radial nerve, and 4 is ulnar nerve. MRU. Mr. U. So shoulder depressed and abduct. Elbows extended. Forearm is supinated, wrist is extended, fingers and thumb are extended, cervical spine, median nerve. So the only difference between ULNT1 and ULNT2 is that the shoulder is externally rotated. Okay, so depressed and abducted. And this says 10 degrees for the ULNT2. That's interesting. So you're only abducted about 10 degrees. Elbow extension, supination, wrist extension, finger extension, and external rotation of the shoulder. That's interesting. UNLT3, you're going to again be depressed and abducted. Elbows extended. Forearm is pronated. Wrist is flexed and ulnar deviated. Shoulders internal rotation, contralateral flexion. Radial nerve. Ulnar nerve, depression, abduction from 10 to 90. Hand to the ear. Elbow is flexed. Forearm is supinated or pronated. Wrist is extended and radial deviated. Fingers and thumb are extended. Shoulder is externally rotated. And then cervical flexion to the contralateral side. Ulnar nerve. And those are the boxes to show what that looks like. Pay attention to the examiner's hand is maintaining shoulder depression. So with A, this one here is ULNT1. And that does not look like abduction to 110 degrees to me. That does. B does. And B is ULNT2. That's interesting. And this says 10 degrees of abduction. So maybe they got it twisted. C is abducted at 110 degrees. And 4 is either 90 to 10. That's interesting. The pictures aren't matching the description. Okay. Upper limb neurodynamic tension test. Normal and pathological signs and symptoms. Normal would be a deep ache or stretch in the cubital fossa. Deep ache or stretch into anterior and radial aspect of forearm and radial aspect of hand. Tingling to the fingers supplied by appropriate nerve bias. Stretch in anterior shoulder area. Above responses increase with contralateral cervical side flexion. Above responses decrease with ipsilateral cervical side flexion. A pathological positive upper limb neurodynamic test would be production of patient's symptoms through concordant pain. Most important feature. A synthesizing test in the ipsilateral quadrant alters the symptoms. Different symptoms between right and left. Contralateral quadrant. Okay, and these are my school slides. Mobility between the nerve root and its investing sheath. Same movement in lumbar spine occurs in C-spine, cervical spine. Occurs maximally at C5, C6, lesser at C7, and lesser at C8, T1. AKA brachial plexus tension test, used an ordered sequence of movements to stress various tissues. Neck position, important to add increased stress to the system. A positive test is reproduction of symptoms, side-to-side differences, synthesize symptoms with neck movement. And the median nerve, this is what we were taught in school. Check resting symptoms. Shoulders stabilized with fist into table to prevent block elevation. Check symptoms. Hold arm by wrist. Elbow flexion using thigh. Shoulder abduction 110 degrees. Check symptoms. Forearm supination. Wrist and finger extension. Ulnar deviation. Check symptoms. Elbow extension. Check symptoms. Cervical side bending away. Check symptoms. You're supposed to check symptoms response after each component. If reproduced, add ipsilateral side bend to see if symptoms decrease. The median nerve, interosseous, anterior interosseous nerve, C5, C6, C7. The median nerve originates from the lateral and medial cords of the brachial plexus. It innervates the palmar surface of the 3.5 fingers, muscles in front, anterior, and part of forearm, muscles of the thumb, muscles that flex and extend the fingers, the lumbricals. Surprised I don't have a picture there. I think that would be good to have a picture there, don't you think? Let's go find one. Okay, so I pulled up the median nerve in the Netter's Anatomy. You see that it's right down here. This is part of the thumb and these 2 fingers and half of the 3rd finger. And then on the back side, the thumb and the ends of these 2 fingers and half of the 3rd finger. So there's the median nerve right there. That's why wrist extension puts pressure on the median nerve. Stresses it. Here's the median nerve here. So that's why you would abduct to put stress on the median nerve. Comes from the lateral and the medial cords. Here's the 3 cords. So here's the lateral cord, here's the medial cord. So these cords come together and make the median nerve. It's the middle part of the elm. Here's the median nerve right here. So that's why shoulder abduction is going to put stress on it. Visuals are everything to me. Here's a median nerve right here. Let's know what compartment the median nerve is right there. Here. And here. medium nerve right here. Wrist extension, see that? Medium nerve. So I'm going to put stress on that nerve. Here's the medium nerve. Medium nerve in the wrist. Medium nerve. Let's go back out and look at those fingers. So this is why the fingers would need to be, see the median nerve, 1, 2, and 3. See how the ulnar nerve takes over here on the other half of the third finger here? So this nerve, and half of the third finger. Medium nerve. Median nerve. That's why elbow extension is going to stress that nerve. It's where it runs. Elbow extension, wrist extension. Ew, that's a good picture. I like this picture. I like it a lot. See where that median nerve is going? Straight down. Here, elbow extension, wrist extension, finger extension. So it's not really hard to see why the position of that's the ulnar nerve. So we'll stop there and go back. So the median nerve innervates the palmar surface of the 3.5 fingers, muscles in the front anterior part of the forearm, muscles of the thumb, muscles that flex and extend the fingers, the lumbricals. Okay. And that is from the Cook book. Is it Cook? Pretty sure it's Cook. Block the shoulder. Forearm is going to be supinated, wrist and fingers extended, ulnar deviation. So towards the pinky. Ulnar deviated. So why are we ulnar deviating? Because we want to put tension on the median nerve that innervates the thumb and the first 3 fingers, right? So we want to ulnar deviate to put stress on it. Okay. What's next? We already did the median nerve. So let's go back to this. So, shoulders blocked, abducted 110, forearm is supinated. Supinated. Why? Because it's going to externally rotate that shoulder too. When your arm's out and in a 110 of abduction and you supinate, you're also going to externally rotate your shoulder. The wrists are going to be extended, the fingers are going to be extended, and you're going to ulnar deviate. Elbow extended, and then neck laterally flexed. Radial nerve. Okay, so let's see, what's that? 14. The radial nerve is the, I'm going to copy this. Control C, come down here. Paste. Okay, so it's this one now, here. So let's go to the netters and let's look at the radial nerve. I think it really helps to look at get a visual of what we're looking at here. Radial nerve. So the pink is the radial nerve, the outside of the arm, the back side of the arm, the elbow joint here, back of the forearm, and then the back side of the hand, the thumb and the first two fingers, the first finger and half of the second finger. That's because the median nerve does the other three, right? Yep. There's the radial nerve. Radial nerve up here. See that on the outside of the elbow. Lateral. Here it is over here on the back side of the forearm. It's lateral. Radial is lateral. Into the thumb. There's the radial nerve right there. There's the radial nerve. It's part of the posterior cord. Posterior cord. C5, 6, 7, 8, and T1. Posterior cord. Posterior, which makes sense because it's a posterior elbow, posterior forearm, and look where it is here. So there's the bone and there's the radial nerve. Let's go back up to this one. Radial nerve right there, lateral. So in anatomical position, it's going towards your thumb. Lateral. Radial nerve is lateral, posterior and lateral. There's the radial nerve right there. Yep. Has a deep branch and a superficial branch. There, going lateral. There it is again. There at the elbow. Right there in the anatomical snuff box. Radial nerve. So in the hand, you're seeing the superficial branch that's going into the thumb. Here's the radial nerve, right here, the pink superficial branch outside of the thumb. That CMC joint right there. Thumb. The back of the first two fingers and the thumb, but not the tips. The tips is the median nerve. Back of the forearm, in the middle of the forearm. See how the radial nerve here is in the pink? Yeah, lateral at the elbow joint. Here it is, right here. Then it goes down to the front, the back side. This is the tricep right here, the elbow joint. the olecranon right in here, back of the forearm, back of the hand, but not the tips of the fingers. Oops. There, posterior cord. Radial nerve. See when it highlights there? Back of the forearm. See that? Going to all of these muscles here. Extensor carpi radius longus. Extensor digitorum. Oh, from the radial nerve right in here. So getting a visual of what that nerve does, where it runs to, is going to, we don't need all that, is going to help us understand why the position of the hand and the arm and the shoulder and the elbow, why it needs to be where it is. So we've got depression and abduction. So we're depressing the shoulder, we're abducting to 110. We're extending the elbow. We're pronating, okay? Pronating the forearm. We're flexing the wrist. Flexing because the radial nerve innervates the extensors of the wrist. So we're going to flex the wrist and we're going to ulnar deviate. So we're going to take it away from the thumb, because it innervates the muscles of the thumb. So flexion, ulnar deviation. Okay? The shoulder is going to be internally rotated. And then you're going to take your head to the side. Radial nerve. It's a nice little visual. Okay. ULTT 2, radial nerve. Shoulder depression, abduction 90 to 110, internally rotate. The forearm is pronated, the wrist and thumb is flexed, and the elbow is extended. Your elbow is flexed and then you extend it. Let's go back here. Where's elbow? Elbow extension. So the elbow is extended for the median nerve and the radial nerve. Okay. Now we're at the ulnar nerve. So I'm going to go, I think I already have it copied. So let's just add it here. Okay, so the ulnar nerve. Depression and abduction. Same. Hand to the ear. Now the elbow is flexed. The forearm can either be supinated or pronated. We learned pronated. The wrist is extended and radial deviated, so towards the thumb. Why? Well, let's go back into the netters and let's look at the ulnar nerve. It really helps to look at it. Ulnar nerve. Okay. I might have to do 2 videos because this one's going to be pretty long. But it's fun to learn this way. Okay, ulnar nerve right here. These 2 little fingers, see that? The outside of the hand, actually it's an anatomical position, it's the inside of the hand. Yeah, right there. 1.5 fingers, because this is medium nerve. This is ulnar nerve. This is radial nerve. So ulnar nerve gets the entire pinky and half of the ring finger. half of the ring finger. And that's your ulnar nerve there. So ulnar nerve is going to the pinky, to the little pinky. Ulnar nerve to the pinky. Here's the groove for the ulnar nerve at the elbow joint. The ulnar nerve is part of the medial cord. So let's review. Medium nerve is part of the lateral and medial come together. Make the middle part of that M. Here, down, here, down. The radial is the posterior cord. And the ulnar nerve is the medial cord. Medial cord, which makes sense, right? Because when you're in anatomical position, it's going all the way down to the thumb, and the thumb is medial. So medial cord, here it is, right here, medial at the elbow. See that right there? Medial. There's the ulnar nerve. Here. Ulnar nerve, all the way down. Oops, let's go back up and look at that. The ulnar groove for the ulnar nerve. And there it is, right there. There it is, right up there. This is the medial epicondyle of the humerus. And the ulnar nerve runs right there by that sucker. So if you hit your medial epicondyle of your humerus the right way, you're going to, that's not so funny, is it? It's not the funny bone. Ulnar nerve, medial. See. Peeling away. Oh, there it goes. All the way down. Ulnar nerve, back, down to the pinky, right there. Ulnar nerve. Highlights all the way down to that pinky bone. See? Peeling away those muscles. You can see the nerve really good right there. Yep. Right to the hook of hamate. Oops. Let's go up and look at that one again. Right there. Right there to the little pinky. Little pinky. See the ulnar nerve there? I love looking at anatomy. It's so much fun. There it is, right there. Right there. Right there, ulnar nerve. Not only do I love anatomy, but I love, here it is right there, digital books. There we go. Ulnar nerve, outside of the hand, the entire pinky, and then half of the ring finger. The back of the hand, the entire pinky, most of the back of the ring finger, shares it with the medium nerve, and then it gets half of the middle finger. So look at that middle finger. Boy, I tell you, the back of that middle finger, we got radial, ulnar, and median. When somebody gets on your nerves, boy, they get on all three of them when you give them the middle finger, huh? You're on my median, my radial, and my ulnar nerve. That's funny. I crack myself up, I really do. There it is. Watch it. Go all the way down. All the way down. Yep. There it is again. Medial. See? Medial. Right behind that elbow, all the way down. Hook our handmaid in the hand. Oops, let's go look at that one again. Ulnar nerve right there. Right in that brachial plexus. There it is again. Ulnar nerve. Hey, there's our slide. I like this slide a lot. Ulnar nerve here, C7, C8, T1, back of the elbow, medial epicondyle. It innervates the flexor digitorum profundus, flexor carpi ulnaris, all the way down to that little pinky. Let's see. It innervates the abductor digiti minimi, the adductor pollicis, which is the thumb, which is interesting, right? Because it's all the way, the deep branch of the ulnar nerve does the adductor pollicis. The dorsal interosseous muscles, the flexor carpi ulnaris, flexor carpi ulnaris, okay, flexor carpi ulnaris, flexor digiti minimi brevis, flexor digitorum profundus, the lumbricals, third and fourth, opponens digiti minimi, little pinky, palmar interosseous muscles, palmaris brevis. Okay, so there you go. Depression, abduction, hand to the ear, elbow flexion, supination or pronation, wrist extension, radial deviation, so it's going to go towards the thumb. Okay, finger extension, external rotation, contralateral side flexion. So ulnar nerve C8, T1. Here we are again. Shoulder depression, abduction, externally rotated. Wrist and fingers are extended. Further abduct the arm to hand to the ear. Compare sides. There you go. Now we're to the slump test. Slump test. "53 minutes. Wow. So on the slump test, the patient sits erect with hands behind back, first position. Patient slumps lumbar and thoracic spine, while either patient or examiner keeps the head in neutral. Examiner pushes down on shoulders while patient holds head in neutral. Patient flexes head. Examiner carefully applies overpressure to cervical spine. Examiner extends patient's knee while holding the cervical spine flexed. While holding the knee extended and cervical spine flexed, the examiner dorsiflexes the foot. Patient extends the head, which should relieve any symptoms. If symptoms are reproduced at any stage, further sequential movements are not attempted. Slump test. Slump test and its modifications. And we didn't learn all this stuff, but this is interesting. Slump test 1, spinal cord, cervical, and lumbar nerve roots, and sciatic nerve. Slump test 2, obturator nerve. Side-lying slump test 3, femoral nerve. Long-sitting slump test, spinal cord, cervical, and lumbar nerve roots, sciatic nerve. So this is the modifications. The first slide we saw was the basic. So C is going to be the femoral nerve. D is going to be the spinal cord and nerve roots. A, so we need to move this up. I don't know why it's out of order. So this is the basic slump. This is the slump test 2, which gives the obturator nerve. So what's different here? Flexion, 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 extension, dorsiflexion. What's different? Oh, what's different? Abduction. That's what's different. Abduction is different to get what? Your obturator nerve, of course. Yeah. Okay, so the big differences between the slump test 1 and slump test 2 is that the hip is also abducted to get your obturator nerve. Okay, so that's what this looks like. Abduction to get your obturator nerve. Then side-lying slump and long-sitting slump. So the cervical spine is flexed, and then in long-sitting you're also going to get it rotated. Flex, flexed, long-sitting is going to be rotated. Thoracic and lumbar spine is flexed in a slump, okay? The hip is going to be flexed 20 degrees and flexed 90 plus. So flexed 20 degrees, and then sitting the hip is flexed 90 plus. The knee flexion with a sideline slump, extension with a long sitting, of course. The ankle and sideline is going to be plantar flexed, and then in long sitting it's going to be dorsiflexed. So with the sideline you're getting the femoral nerve, plantar flexed because the femoral nerve is anterior, dorsiflexed because you're getting cervical and lumbar nerve roots and the sciatic nerve. So all makes sense. Okay, straight leg raising. Radicular symptoms are precipitated on the same side with straight leg raising. B, the leg is lowered slowly until pain is relieved. The foot is then dorsiflexed, causing a return of symptoms. This indicates a positive test. To make the symptoms more provocative, the neck can be flexed by lifting the head at the same time as the foot is dorsiflexed. So A, B, leg is slowly lowered. Oops. Foot is dorsiflexed, and then the neck can also be flexed here. Okay, well, let me go find my straight leg raise in my other books, and I'll be right back. Okay, so this is, I went and pulled some slides from my coursework, special test part of lower extremity screening. straight leg raise, tension sciatic nerve, passively flex hip with knee straight. Ask about symptoms. Can also passively add dorsiflexion. Here's why I went and looked for my coursework, because the previous slide from the Maggie book did not talk about this part right here. Positive test, symptom reproduction at less than 70 degrees of flexion. So, at less than 70 degrees of flexion. Straight leg raise has been found highly sensitive, negative rules out, however, is not very specific, rules in. If symptoms reproduced on opposite leg, that is a contralateral straight leg raise, which is highly specific for a bulging disc. Straight leg raise. Positive if back or leg pain at 40 degrees or less, from the cookbook. Cross straight leg raise. Performed as straight leg raise but on the uninvolved side. Neuromeninges are pulled caudally, resulting in compression of the dural sleeve against a large or medially displaced disc herniation. It's positive if it reproduces symptoms in back or involved extremity. So you're flexing the uninvolved, and it's positive if it reproduces symptoms in the back or the uninvolved lower extremity. Synthesizing maneuvers, dorsiflexion with hip internal rotation or adduction for the tibial nerve, plantar flexion with hip internal rotation and adduction for the fibular nerve. Let's see. And this is to differentiate between a spinal nerve and a peripheral nerve. Okay, let's see. All right. Back to that. Straight leg raise. 1, 2, 3, 4. A, B, C, D. I think this probably needs to go up here. So this slide doesn't actually name this, but you got hip flexion and adduction, knees extended, ankles dorsiflexed, sciatic nerve and tibial nerve, straight leg raise 2, flexion, extension, dorsiflexion is the same, and you evert and extend the toes, tibial nerve. Flexion, extension, dorsiflexion. Then you invert to get the sural nerve. Flexion, internal rotation, extension, plantar flexion, inversion. So plantar flexion, inversion, you get the common perineal nerve. And then you've got the cross, and I'm assuming they're talking about the cross straight leg raise. Flexion, extension, dorsiflexion, nerve root, disc prolapse. So that's pretty much what we just went through here. Yep. Said it even better. Okay. So, wrist and hand. I think I'm going to stop this video here and do another video on the wrist and hand. That nerve bit kind of took a little minute, don't you think? So we're going to go ahead and stop this here, do another video.